ketamine therapy. This is something that I didn't think that was done in doctors' offices, to be honest with you, until about 18 months ago. And I've had a few patients that have gone through this with good results. This is something you do in your office, correct?
We do ketamine, yeah.
So talk to me about this, educate me on this. For quite frankly, I don't necessarily know the physiology of how this works and how you would prescribe it.
Yeah, just to give some background, and ketamine is very prominent in the last 5 to 10 years, so most people might know about it. But ketamine is classified as an anesthetic agent, so it's used to put people to sleep. It's one of about 4 induction agents that you can use to put people to sleep initially. It works primarily in terms from a pain perspective, on a receptor called the NMDA receptor, which is different than opioid receptors and some other pain receptors. And the thought process is that it actually activates that receptor and kind of downregulates some of the opioid receptors, and because of that, has its own pain benefit. Now, in terms of what conditions is it good for, the best data is actually for depression.
Interesting.
That seems to be the best data. There's something about kind of resetting those receptors in the brain. It doesn't seem to be quite as effective as something like ECT, which has been an electroconvulsive therapy, which has been around for almost over 60 years now, and is kind of barbaric in some regards, but very effective. So, but from a pain perspective, I actually did my grand rounds on this because I was very interested in it. And again, we're having some of the same challenges with ketamine that we have with, say, stem cells. It's going to be, what's the dose? What's the frequency? How long do we expect it to work for? And what conditions does it seem to work for? Is it a panacea for all chronic pain? And it's definitely not. It seems to work best for very neuropathic conditions, so nervous system related conditions that usually are resistant to other treatment options for pain. And in terms of duration and effect, there seems to be a good pattern with rapid short-term doses, kind of relatively high doses for maybe 1 or maybe 2 to 5 days in a row. If you can do more days, you typically get a longer effect. But for chronic pain syndromes or CRPS, another condition we can talk about, which is we've seen in our patient population frequently, we seem to see a duration of relief, depending on those parameters, maybe 12 weeks, sometimes longer. Now, we don't recommend this treatment to everybody as an initial line therapy. It ends up being kind of down with PRP, where it's a sort of end stage. We've tried a lot of the traditional options, and we are at a place now where we don't know what else to really do for you, and so let's try that. So we do have a few patients in the practice that come in, and we'll get those in infusions.
I was thinking that you were going to say this was more of a microdosing situation versus a big bolus a couple times.
So what is microdosing versus what is a bolus, and so an induction dose, not to put you to sleep, is going to be like 1 milligram per kilogram. So you're talking like if you're 200 pounds, 1 milligram per kilogram puts you at about 100 milligrams. Like boom, that's really high. You're gonna, because it has some psychogenic properties. You can have hallucinations, and they're usually not good hallucinations.
I was going to say, are people having like pretty crazy side effects with this, I assume, because of that?
So you want to titrate the infusion and the dose to just before you're getting bad side effects. And the patients be aware of that. They'll say, I'm feeling, initially they'll feel kind of weird. And then if it gets to be a little too high, they'll be like, I don't feel right. This is getting to be too much, or it's not enough. And so we can augment that with some other medications to help decrease that if we're trying to get to a higher dose, or we back off the dose and maybe run the infusion a little longer if we need to.
It's interesting. What do you think the future of that is? Just honing in on the dosage, or what do you think the future is of that?
It's challenging. There's some new brand name ketamine intranasals out, and some orals and stuff, and that seem to be, I think Spravato is one of them, and they seem to be having some good long-term effects. We do have a couple patients that do take that. Obviously, the risk now, what was that, about a year ago, Matthew Perry had overdosed on ketamine. So it ends up always being like a balance between, what's safe and effective, and then, what puts people at risk, and, how can we mitigate that? So I think for the right patient, the right condition, in the right hands for the right reason, it can work really well. But just like with most pain treatments, you got to have the right patient and the right condition that you're treating
Right.
to have an effective outcome.